I'm Dr. Eric Marsden, Clinic Director for the Marsden Center for Excellence in Integrative Medicine. I'm also the course instructor for the Mistletoe Therapy Certification course for cancer patients. I also sit as the chair for the Oncology Association of Naturopathic Physicians Committee on Principles of Care for Naturopathic Practice in Cancer Patients. In this webinar, we're going to review the various benefits of mistletoe therapy in cancer patients. When I was introduced to mistletoe therapy almost 20 years ago during my postgraduate training in Europe, I was amazed at how such an impressive therapeutic was relatively unknown here in North America. It is most likely the best and most well-researched integrative therapeutic for cancer that we have in our armament. It can positively impact patients at almost all levels of their care and their treatment spectrum. Whether we're looking at trying to provide supportive care for patients undergoing conventional treatment, either in a curative or palliative setting, whether we're looking at post-treatment, recovery, restoration, and of course secondary or recurrence prevention, or in patients who are at very high risk for disease, maybe because of genetic predispositions or other types of exposures, we could maybe look at implementing mistletoe as a preventive strategy. Mistletoe is a very safe as well as effective therapeutic that has a robust database, both in clinical trial as well as post-market surveillance and monitoring in Europe, especially where it's been a licensed drug for almost 100 years. In this webinar, we'll talk about the basics of mistletoe therapy, some of the research behind it, how it's generally administered, and hopefully I whet your appetite enough that you want to join us for the full certification course. I hope you enjoy. So in order for us to get a clear concept of the importance of mistletoe therapy and integrative cancer care, we have to get a real sense of what the problem with cancer is globally. And I think intuitively we all see this in our clinical practice, increasing numbers of patients being diagnosed with cancer, and in many cases younger patients being diagnosed with cancer, more aggressive cancers. When we look at it globally, there were almost 14.1 million new cancer cases and 8.2 million cancer deaths, and actually the 32.6 million people living with cancer back in 2012, which is really the most recent data we have globally. And the men, as we know, are about 25% higher rates of incidence of cancer. And you can see here in this chart the different countries, the breakdown in terms of both incidence and mortality. And you can also see in the less developed regions there are less incidence and mortality associated with that. And there are a variety of reasons. Some it has to do with life expectancy being shorter in some of those developed regions, but also there's a very large difference in lifestyle that also could be predicating some of these risks. I think we all hear that in many ways through novel approaches in conventional treatment, in terms of therapeutics as well as early diagnostics, we see improvements in overall mortality and incidence. And we hear this concept that we're winning the war on cancer. And while that is true when we look at it statistically, there is a story underneath. And so the reason why I put this chart together is so that we can understand that the statistics that we are being told are what we call age-adjusted statistics around incidence and also mortality. And what that means is that these incidence rates have actually been kind of artificially altered so that it reflects the changing demographic of our population, meaning we're having an increasingly aging population. And we expect to see more cancers in an increasingly aging population. The diagram that we have here looks at the Canadian situation, which is where I live and practice, and how the crude rate, which is that solid red line, is actually on a relatively linear increase from 1992 all the way to 2012, whereas we see this age-adjusted rate on the top for the 2011 standard versus the 1991, you can see what happens to that incidence over time. It kind of flatlines the actual incidence. So just to know that when you hear statistics saying, yeah, we're winning the war on cancer, that doesn't necessarily mean we're not seeing more people diagnosed with cancer, nor does it mean that we're not seeing more people dying of cancer, but that because of these age-adjusted rates, that crude rate could be misconstrued. And then finally, when we look at this concept of survivorship and how many people are surviving with cancer, these are statistics from the U.S. and the American Cancer Society as of 2016, which is the latest data that we have. And you can see that as of January 1st, 2016,
there are almost over 7 million men and 8 million women who are cancer survivors who've been diagnosed with cancer and who are living either with chronic living with cancer or in a cured remission state. But even more important or surprising is if what's this picture going to look like 10 years from now if we sort of look at the current rate. And in this situation, we see, really another 5 million cancer survivors, so almost 10 million men and over 10 million women. And this, really presents an important problem for healthcare. And so what are these implications of survivorship? Well, we know that 1 in 4 cancer survivors report reduced quality of life due to physical problems. 1 in 10 have mental emotional problems. And we know that people who were having more aggressive or invasive treatments and who were suffering from more quality of life issues during those treatments, they're at an increased risk of having long-term quality of life impacts. So what are we talking about this? Well, we're saying, listen, there are more people being diagnosed with cancer year in, year out, both within North America and throughout the world. That while there are more survivors because of wonderful advances in conventional treatment, a lot of these treatments are more invasive and aggressive, and they can lead to substantial quality of life impacts. And we think about just in the US alone, there are people that, if we think a quarter of those cancer survivors have quality of life impacts, that's a huge number of patients, in the millions and millions of patients. And so if we have a therapy both during treatment and afterwards that can positively impact quality of life and mitigate or reduce some of those side effects of these aggressive invasive treatments, man, wouldn't that be amazing? And really this leads us to the importance of integrative oncology and then more specifically Mistletoe. So when we look at conventional oncology, this is sort of above the line here. The goal in conventional oncology is to reduce the cancer burden, interrupt the course of disease, and treat locally effective areas. And really the 3 prongs of conventional oncology treatment are chemotherapy or targeted treatments like the monoclonal antibodies and enzymatic inhibitors, surgery or ablative therapies, and then radiation treatment. And then under the line, we have these sort of integrative treatments or these non-conventional treatments. And these include biological agents, which Mistletoe, I would say, is a part of, diet and lifestyle, and mind-body interventions. And the goals of these therapies are really to strengthen the patient, to enhance immune function, and promote wellness. And I think if we can treat both above and below the line, at least from this diagram, we can really give our patients the best opportunity to have an effective treatment process and a better long-term survivorship pathway in terms of trajectory of survivorship and mortality, as well as quality of life. So what about mistletoe? Mistletoe has a long history of use in traditional medicine, but when we're looking specifically at cancer, its early use was started by Rudolf Steiner, who was the founder of the philosophical field of anthroposophy. And he really postulated that mistletoe may have potent effects in cancer, and he lectured to doctors in the early 20th century. And in those lectures, he suggested a variety of specialized ways in which mistletoe might be harvested and processed to give these clinical effects. And interestingly enough, he actually recommended different mistletoe preparations being created from mistletoe growing on different trees. And we'll talk about how mistletoe grows and the fact that it is sort of a semi-parasitic plant that grows on other plants, particularly trees. And what's really neat is that these early philosophical thoughts of this great philosopher Rudolf Steiner actually pan out, that there are definite clinical differences between products that are made from plants grown on various types of trees. Now, the first injection of mistletoe for cancer patients was done in 1917. So mistletoe actually celebrated its 100th anniversary of use in cancer patients last year. And there were a lot of wonderful and important events that were surrounding that, particularly in Germany. But it has been around for a very long time. Mistletoe has so many wonderful effects. And this is why it's such an important part of my clinical practice. and why I'm so passionate about teaching it. You know, when I was first exposed to mistletoe in Europe, I thought, my gosh, why was this not a part of our education, from a naturopathic education or integrative cancer education? And it still seems to be a relatively um, unknown therapeutic compared to some of the other more popular therapeutics from a North America perspective. But really, it does help the patient in so many different ways. You know, we can look at the immunological effects by increasing both the number and activity of immune cells. It can actually cause a short-term liberation of inflammatory cytokines, particularly you know, a productive inflammatory response rather than this sort of long-term chronic smoldering inflammation we see in most cancers. And you know, the interesting thing is, while we get this transient upregulation of inflammation, we can get a reduction in the long run. There is a direct cytotoxicity due to ribosomal protein synthesis inhibition and anti-angiogenesis. There's this, you know, patient support, or these neuroendocrine support, that can be seen because it can induce beta endorphins, and it has antioxidant effects. It can affect melatonin and cortisol curves. So it's just this wonderful therapeutic that can create all of these wonderful biological effects. Here are a variety of the substances that we find in mistletoe that have been studied to date. We have the glycoproteins, which are probably the most well-studied element of mistletoe, and in particular the mistletoe lectins. You'll see there are 3 different subtypes, 1, 2, and 3, one having the greatest level of direct cytotoxicity or cancer cell inhibition. We also have the viscotoxins, which also have additional cytotoxicity, causing lysis of cell membrane. We have these polypeptides. We have these the polysaccharides. These are actually very similar in terms of the arabinogalactane and rhamnogalacturonane. These ones actually are very similar to what we find in mushrooms, and has those immune modulating effects in mushrooms. And then we have all these other bioflavonoids, which are found within the berry part of the mistletoe. So all of these substances have effects on the immune system, and many of them are directly cytotoxic on cancer cells. Here's a summary of those immune effects that we talked about earlier: the increase in granulocytes and lymphocytes, increase in large granular lymphocytes, increase in natural killer cell activity, stimulation of phagocytic activity, liberation of those inflammatory cytokines, transient liberation of inflammatory mediators like CRP. Then clinically, we see these patients have an increase in body temperature, which is really neat because often cancer patients are quite cold. They've lost this normal diurnal rhythm of increasing body temperature throughout the day. We get an eventual induction of anti-mistletoe lectin antibodies, and that's another effect on the immune system. Another important effect of mistletoe on the immune system that has particular relevance for those patients undergoing chemotherapy or radiotherapy is this protection of immune DNA by mistletoe. And here are a variety of different studies that summarize some of the publications by Dr. Büsing in Germany and his research group. And you can see that mistletoe can protect both in vitro, and there are also a couple of clinical studies looking at better natural killer cell activity in patients who are being treated with mistletoe. So this sort of protection both in vitro and in vivo, both in animals as well as in humans in clinical trials. And we know that better NK activity is associated with better outcomes in cancer patients. Here's a diagram of how mistletoe lectins work to mediate cytotoxicity. We see this binding, or this phagocytosis, or the taking in of the mistletoe lectin molecule by the cell, and that mistletoe lectin has a direct interaction with the ribosome, inhibiting translation of RNA into protein, and also inhibiting post-translational modification. And then that leads to reduction in protein synthesis, which creates this sort of downward cascade of effects on the mitochondria, and eventually liberation of the different caspases, and leading to apoptosis. This is an interesting summary of a clinical study. This is an in vitro or in vivo study in rats, looking at the effects of mistletoe on the microcirculation of the tumor. And we have 2 pictures here of the blood distribution in the tumor before treatment with mistletoe. And then you can see on the right-hand side of this image the circulation to that tumor after a single application of mistletoe injected to that tumor. And so there are some of the proteins in mistletoe have a strong anti-angiogenic effect. We talked about at the beginning of the biological effects of mistletoe, those neuroendocrine actions of mistletoe, and that's that one of those is actually sometimes improvements in pain with patients. Actually, intravenous mistletoe application was first used for the purposes of trying to induce pain relief in patients with tumor-related pain. And what we can see is because of this unique stimulation of the immune system, we can actually get our T cells, our NK cells, to release endorphins. And this endorphin release can lead to improvements in well-being, a sense of well-being, as well as reductions in pain. So this is a sort of a natural endorphin, that natural feel-good chemical that is produced by our bodies. There have also been a few clinical studies that looked at mistletoe effect on the stress response in cancer patients and on cortisol. And here's an example of one small clinical trial that looked at patients who were treated with mistletoe, and they showed that these patients had lower basal levels of cortisol and actually had a normal diurnal rhythm of cortisol when they compared them to patients who were not treated with mistletoe. And interestingly, those patients who were treated with mistletoe actually showed better anxiety and depression scores. So again, these are improvements in patients receiving treatments where we know there are high rates of anxiety and depression, and that we know that depression and anxiety can actually be a contributor to poorer outcomes in these patients, and mistletoe can help with this. Now, one of the things that I'm constantly hear, either from patients as well as from some clinicians, both conventional and non-conventional, but mistletoe is this really toxic herb we have to be careful of. And I think mistletoe has been sort of maligned. It is not as toxic as I think we have been led to believe. A simple small ingestion of a single berry will not lead to horrible toxic effects and immediate death. I think that a part of this misnomer maybe comes from Norse mythology and the fact that mistletoe is the plant that's responsible for Baldur's death. However, mistletoe is not without any toxicity, but the toxicity is much higher than I think what most of us expect. The symptoms of ingested mistletoe toxicity include nausea, vomiting, diarrhea, and hypertension, and in some cases can be followed by shock. When we track the case reports of toxicity or poisoning by both North American or American mistletoe as well as European mistletoe, there really are very few cases of poisoning, and in fact, in most cases of accidental ingestion, 97% were asymptomatic. Based on this data, the conservative estimate of toxicity is 1 to 3 mistletoe berries or 1 to 2 leaves really won't create any symptomatic toxicity and will certainly not require any treatment from a poison control perspective. When we look at post-market surveillance, when we look at in vitro preclinical data, when we look at the clinical research data, when we're using standardized mistletoe extract from a clinical perspective, the doses that would be required to provoke toxicity to create these kinds of symptoms are not achievable in any realistic way through regular clinical administration. So, there have been 2 cases of death due to mistletoe preparation in the past 25 years, and in those 2 cases were with dried plant teas. Usually, and in both cases, there were repeated administrations of high quantities of the dried herb. So the upshot of this is mistletoe is a wonderfully well-tolerated, reasonably non-toxic, especially at clinically relevant doses, herb. And just to summarize the mechanisms of actions of mistletoe, I've given you a simple diagram. I'm obviously being quite sarcastic about this. There's a lot of complexity here, but this is just a nice diagram looking at the different interrelated relationship of mistletoe injected under the skin in a patient, which is the normal mechanism or mode of administration of mistletoe, and how this can affect immune function, activate different cells, which can lead to liberation of different cytokines or chemical messengers, which can create the clinical effects we see in patients. And we see right at the bottom here, we can see the improvements in things like bone marrow function, the psycho-emotional sphere of the patient, and of course, the tumor or cancer entity itself. So what kind of clinical investigations have been done with mistletoe? And certainly for the purposes of this webinar, I can't really go into so much detail. If you do decide to participate, which I hope you will, in the full certification course for mistletoe therapy in cancer patients. We go into more detail about mistletoe research. We go into some of the common criticisms of mistletoe research and why there are challenges associated with doing research with mistletoe. But I wanted to give you a little bit of a sampling of the clinical research that's out there, and kind of whet your appetite, if you will. And one of the other big reasons why I want to do a little bit of a sampling here is I continue to hear, particularly from my conventional oncology colleagues and oncologists, at least in Canada, that there's no research in mistletoe. There's no evidence to say it's helpful. And while we might be able to argue that maybe there are issues with some of the clinical trials, that perhaps there could be better quality of evidence, there are excellent studies that have been done with mistletoe. There are good quality studies that have been done with mistletoe, and there are dozens of those studies. So certainly, as you'll see, mistletoe is a well-studied therapeutic for cancer patients in an integrative setting. And here's a simple retrospective study. Prior to the late 90s and 2000, most of the research was done either a short case series or small clinical trials and or retrospective data. And while we know that from an evidence perspective they're not as strong, I think it's important that we look at those because there is some compelling information there. So this was an example of 5 studies that were done at the Herdecke Hospital and looking at comparing to the cancer registry in that area. And they looked at 5 entities: lymphoma, leukemia, pancreatic cancer, malignant melanoma, breast cancer, and colorectal cancer. And here is a bit of a summary of the number of patients who are enrolled, both at the Herdecke, which is the GKH, and the EKRS, which is the cancer registry. The number of patients who are alive, and the number of patients who died in that during this retrospective study. And then here's the Kaplan-Meier curves of those different studies. And you can see the green line is the mistletoe line, and the red line is the SEER data. And really, there are some substantial increases in the survival as it appears in this retrospective study with patients treated with mistletoe versus those who are not. Knowing, and we do know that this type of a retrospective study has less power and is prone to more issues, but it's still very compelling. The magnitude of results is very compelling. Here's another example of a retrospective study looking at colorectal cancer back in 2007. And when we look at this, it was a monocentric, single-armed retrospective study, again comparing with the cancer registry. They were looking at that 1981 to 2001, and the outcome measure was overall survival. And why I wanted to put this together is, well, we saw the overall survival depending on the type of cancer. This was one really broke down, well, are there certain patients at different stages who derive a benefit? Well, what about those stage 4 patients? Do they get any survival benefit? And what we can see here is at each stage, whether the patient was diagnosed with early stage 1 disease or late palliative situation stage 4 disease, mistletoe helped in their overall survival. This was a systematic evaluation of mistletoe treatment within chemoradiotherapy protocols, and it was an observational cohort study. And these were looking at patients between 1993 and 2002, both in Germany and Switzerland, in a couple of centers. And they were looking at adverse drug reactions, quality of life, disease-free survival. And what we see here is, overall survival was better, that the adverse events were lower in patients receiving mistletoe therapy, and the quality of life was better in those patients receiving mistletoe therapy. And here's just that survival curve for that clinical study. Again, those patients treated with mistletoe, in this case the preparation was Iscador, versus the control, mistletoe was much, much greater favored. Now, with those types of study, they're retrospective, there are issues with the quality and the ability to derive clear conclusions from that, but I do think that they're important to point out. They were over long periods of time with large groups of patients. And so I think they're interesting to note. Obviously the gold standard is prospective randomized controlled trials, and there have been many that have been done with mistletoe. This is one of the more recent ones. This was looking at mistletoe in pancreatic cancer patients who had locally advanced or metastatic disease. It was a randomized prospective controlled trial looking at overall survival in these patients, and it was published in the Journal of Cancer, European Journal of Cancer in 2013. It was an open label phase 3 study looking at patients 18 years and older with stage 3 inoperable or stage 4 disease. They could have had a history of previous treatments, anti-neoplastic treatments, conventional chemotherapeutics, but they were no longer eligible for that. And these patients were only receiving best supportive care, basically. And the study results showed that the median overall survival was much greater in the mistletoe-treated group versus the non-mistletoe-treated group. Now, one of the criticisms of this study was that, well, geez, the overall survival in general was low compared to what we would see with modern treatment. And that is true. Looking at FOLFIRINOX protocols, we see better overall survival than what would be expected here. But these treatments, these were patients not receiving chemotherapy, so they would have either received chemo or they weren't really a candidate for it. And we see that there was, again, significant improvements in overall survival. And we can see the listing of the different adverse events here. In general, it's very well tolerated. Now, more importantly is, did there, again, like we were looking with the colorectal retrospective study, was there a benefit that was greater or lesser depending on the prognosis? So if we look on the left of this, these were patients who had a poorer overall prognosis, basically a lower ECOG status, maybe more hematological abnormalities, greater burden of disease. These patients still had survival improvements, and those patients with a good or a better prognosis had even more improvements relative to the control group. Now, what about patients with gastric carcinoma? And this was a randomized controlled pilot study looking at immunomodulation and safety of mistletoe. And basically, these were in 32 patients who were operated with gastric cancer. They were waiting for oral chemo with the 5-FU prodrug. And mistletoe was injected, the standard, 3 times a week using a standard escalating dosage schedule, much like what we teach in the certification course. And they looked at quality of life. They looked at blood and immune function and different cytokines. And here are some of those results, and we see improvements in overall functional status, symptom scores, overall quality of life scores between the different groups, and you can see the differences here within the mistletoe versus the control group. And essentially the conclusion of this study was that mistletoe was very well tolerated, it was very safe, the immune and functional parameters were improved in the patients who are under the mistletoe treatment versus the control, and global functioning was better in mistletoe-treated patients. And finally, here's a very interesting study looking at mistletoe in combination with standard conventional care for breast, ovarian, and non-small cell lung cancer patients. And it was a prospective randomized controlled trial, multi-center. This was done in China. And what was interesting about this study and why I bring it on is that the control group in this study was not receiving just conventional standard care. The control group was also receiving a standard supportive therapy that is used in China called lentinan, which is an injectable Basidiomycetes mushroom extract. So when we're comparing mistletoe to the control group, we're also comparing another supportive therapy, mushrooms. And I know that in North America, medicinal mushrooms, in particular, Coriolis, reishi, maitake, they're very popular and have broad use. And I think it's interesting that this has a nice little comparative of not just oral mushroom extracts, but an injectable one, and how mistletoe compares to that. So let's have a look at the data. Well, first, quality of life. Patients who were treated with, in this case, the Helixor extract versus lentinan alone, they had substantial improvements in various markers of quality of life and functional status. So there's the FLIC, or Functional Living Index of Cancer, as well as the TCM score, and then there's the physician-derived score of the Karnofsky Performance Index. And we see statistically significant and clinically significant improvements in patients treated with mistletoe versus the lentinan supportive care. Well, what about adverse events? And here we look at both total adverse events, chemotherapy-related adverse events, and serious adverse events were better, both statistically as well as clinically significantly, in the mistletoe-treated group and in the versus the lentinan or non-mistletoe-treated group. And really, you can see it's almost half of that. I mean, this is a substantial impact. So again, if we go right back to the beginning where we're talking about quality of life, patients who have poor quality of life during aggressive care have more likelihood of those serious quality of impacts long term. Here's a great study that looked at quality of life is better, functional status is better in patients treated with mistletoe instead of just standard care. So again, mistletoe was associated with better quality of life. It was associated with reduced rates of total and serious adverse reactions, and it was favorable to injectable mushroom extract. And this is why I say, quite frankly, if we have a patient who can tolerate mistletoe treatment, which it is a well-tolerated therapy, we should be using that, not necessarily mushroom extracts in those patients. So finally, what's considered the optimum level of evidence is meta-analysis or systematic research reviews, and there have been these reviews done with mistletoe. And this is why, again, when I hear there are no evidence for supporting mistletoe's use, that is just cockamamie baloney. There's a lot of evidence. So first review that we'll talk about was the Cochrane database review, Cochrane systematic review. This was done by a variety of researchers, and we also know that Cochrane is sort of the Bible of systematic reviews. This study looked at 80 studies. 58 were excluded due to a lack of prospective design and or randomization. There were some arguments about this inclusion-exclusion. There are some thoughts by people that they excluded some clinical trials that would have maybe supported more of a survival impact that actually did meet their inclusion criteria. However, they didn't. So 21 total studies were reviewed that looked at over 3,484 patients and 5 different mistletoe preparations. And here we see the sort of summary of the different studies, the different outcomes that were looked at. So they looked at survival, tumor response, and quality of life. 13 of the 21 studies looked at survival, 7 looked at tumor response, and 16 reviewed quality of life. When we look at 6 of the 13 that showed a positive impact of mistletoe on survival, and it was determined that that was an insufficient insufficient evidence to support the assertion that mistletoe improves overall survival. That 7 looked at tumor response, only 2 of 7, so there's insufficient evidence to support mistletoe saying that it improves tumor response. However, 14 of 16 of the ones looking at quality of life showed mistletoe improved quality of life, and they said that's significant but inconclusive because they still had a thought that the quality of the study wasn't exactly what they wanted to be. So let's look at this a little bit deeper. Of the 7 of 13 studies that looked at, the 7 of the 13 studies that looked at survival but didn't show a positive result, 4 of those 7 actually had a statistically non-significant trend towards better overall survival. And perhaps if they had a larger patient base, they may have seen that. But no trials showed a negative trend. And that's really important. So, this study basically, it seems that there is a significant, from this research review, it seems that there was a significant amount of evidence looking at mistletoe improving quality of life and side effects of conventional care. But they felt that there wasn't enough evidence to support survival and tumor response. Well, there was another systematic review. Actually, this one was earlier, looking at mistletoe and gynecological cancers. In this one, it reviewed a whole host of different studies, and I'm not going to bring those charts out. They did look at both randomized and non-randomized, and all showed substantial improvements in overall survival of patients treated with mistletoe and gynecological cancers. And in fact, some of those studies that were good study design perspective that showed the survival advantage that was reviewed in this systematic review didn't seem to be picked up by the Cochrane database review. The most recent systematic review that was done back in 2010, it was published after the Cochrane database review, was looking specifically at quality of life by Kinley and Kine. And they looked at quality of life, and they actually looked at 48 total reviews. 26 were randomized controlled trials, and then there were some non-randomized controlled trials. And among the 26 randomized controlled trials, 22 reported a quality of life benefit, 3 indicated no difference, and 1 didn't report the results. I mean, ultimately what this shows is there's substantial improvements in quality of life with patients treated with mistletoe undergoing conventional cancer care. So, how do we use mistletoe? Now, really, this is the part where mistletoe has some complexities. It is not a simple treatment to administer. There is a variety of unique things that you need to look at, both in terms of patient assessment as well as the preparation. And so there is no way that I can go into anywhere near the level of detail that you would need to be able to effectively implement this in your practice. But certainly in our certification course, we spend a substantial amount of time on talking about how do we assess the patient. How do we make a decision of which mistletoe extract and type we should be using? And then how do we dose escalate these patients and maintain their dosage and assess them for both tolerability and safety as well as treatment response. But I'm going to give you a bit of a summary or an overview of how it's administered. Again, just whetting your appetite and hoping to see you at the certification course. So the mistletoe therapy in practice, it's administered in many ways, and it can be done. The most common on-label mode of administration for the countries where it is registered is through subcutaneous or sometimes oral. However, I will say that in those countries where it is registered as an oral therapeutic, oral administration is really not effective for cancers. When you take mistletoe in orally, a lot of the lectins, viscotoxins become degraded. Those are the peptides, and they get digested before they're absorbed. So subcutaneous is the most commonly used route of administration. However, it has been studied and used intravenously. In fact, in our center, we've done a large safety analysis of mistletoe, and we also have done a pilot pilot observational study looking at mistletoe intravenously for febrile neutropenia in patients undergoing moderate risk febrile neutropenia chemotherapeutic regimens. It can also be administered intravesicularly in the bladder, intrapleurally in the case of pleural effusions, and intratumorally in inoperable lesions. There are some common features of the different mistletoe preparations. There are different types of mistletoe preparations, not just the ones that we talk about commonly in cancer. There are phytotherapeutic preparations and homeopathic preparations. What we talk about in the certification course is really the anthroposophical preparations. These preparations are made with a fresh herb. They are manufactured according to the German homeopathic pharmacopoeia, and they are manufactured to the specifications set out by Rudolf Steiner. Now, the interesting thing is Rudolf Steiner had many different talks on mistletoe use in cancer patients during the early 19th century, and it is because of some ambiguity or some lack of clarity in the talks and the recommendations that we have all of these different mistletoe preparations. So there are significant differences between the different preparations. We speak about the three most commonly commercially available mistletoe preparations, or excuse me, anthroposophical mistletoe preparations in the course. There are a couple of others, but these are the ones that you're most likely to come across and have the broadest availability throughout the world. The fresh herb is usually stored with liquid nitrogen or argon between 4 and 8 degrees Celsius after picking, and then extracted in water. The reason why it's done this way is because the mistletoe can become oxidized, and even changes in pH and oxidation can affect the levels of things like the mistletoe lectins and viscotoxins. This is something we talk about extensively in the certification course. There is a standardization process. It is biologically standardized to effect most. It is also standardized in terms of the process or preparation. It is not standardized to a particular constituent. Some of the phytotherapeutic preparations are standardized to lectin, for example, but in the case of the anthroposophical preparations, because there are so many important parts of the mistletoe extract that play a role in its clinical effects, they are, and it's a whole plant extract, they look at that biological as well as process standardization. So things like harvest time, the constituent amounts, male, female, plant, etc. So the different preparations that we look at for the anthroposophical ones are Abnoba, Hilixor, and Iscador. The other phytotherapeutic preparations are Urixor and Lectinol. And when we look at these different anthroposophical preparations, they can be further subdivided into which plant or which tree the mistletoe plant was grown on. So Abnoba, there are many different subtypes. With Hilixor and Iscador, there are 3 different subtypes. And we go into great detail in the course of which subtype to use in which patients. So when we administer mistletoe, we have a very specific way in which we administer it. And there is some definite experience that's involved sometimes in dose escalation process. And this is one of the advantages of participating in the certification course is you can ask questions in our closed Facebook group, and I'm happy to answer those, and we can share that information throughout the group. But basically, we choose the type based on the patient characteristics. So that's which of the 3 preparations from, let's say, Helixor or Iscador, or the 8 preparations from Abnoba, would we use in a particular patient? Is it both the patient characteristics? Are there any other comorbidities? Do they have any other health issues? What conventional treatments they're on? What's the tumor type? We'll start with a very low dose, and the dose is very different depending on the type of the mistletoe preparation that's used. And then we escalate that dose based on the patient's response. And there are various factors that we take into whether it's a local injection reaction, whether it's temperature variation or fever, whether it's changes in the hematological parameters and so on. And then we maintain therapy for a long duration, in an adjuvant setting, at least a couple of years. And then the key thing about the maintenance therapy is we don't want to have one static dosage. So we actually want to do rhythmic variation of dosage, and then we interpolate pauses, because in the absence of this rhythmic variation and the instituting of breaks, patients can become adapted to it, and actually mistletoe can lose its effectiveness. So I've mentioned the certification course a few times during this webinar. Why should you bother doing it? Well, one, I hope that this has given you enough information to say, hey, I'm taking care of cancer patients, and mistletoe seems like a really safe and effective therapy that can positively impact my patients. Hopefully I've given you enough information that you have that sense. In that course, we go in greater depth into mistletoe science, including more information on its historical use. You get a bit of a background of where it's come from, the fact that it has been used extensively throughout the ages, over thousands of years. We'll talk a little bit more in depth about the toxicology and give you some confidence and comfort in using it and safety. And then we'll go into greater depths around the mechanism of action and how that relates to how you use it clinically, and also go into more detail around clinical research. We'll also talk about how do you assess your patient to ensure that you can apply mistletoe safely and effectively, and make sure you're doing the right choice of therapeutic agent. And then we'll go into that detail, the nitty-gritty of administering it, looking at which choice of the type, how do we escalate the dosage, when do we pause escalation, how do we pause it, how do we resume escalation, when do we resume dose escalation, what dose do we want to set as our sort of goal maintenance dose, what do we do if we don't get there, how do we manage different complications or side effects which are common or rare and significant in mistletoe. And then we'll also talk a little bit about different application methods of mistletoe, and in particular we'll talk about intravenous application of mistletoe as well as intravesicular application, because these are 2 ways in which we can apply mistletoe both off-label, but can have really neat impacts on specific sets of patients in an outpatient setting. So there are other ways of administering mistletoe, like intrapleural and intratumoral. That's more of an inpatient type treatment and not common outside of institutional setting. So if you take part in that course, you'll find that there's a lot of resources. So some of those resources include patient assessment checklists, assessment tools that you can use to monitor quality of life, side effects. Is the treatment working well? Is the patient tolerating it? Office policies and procedures for mistletoe treatment that you can implement in your clinic manuals, consent forms, patient handouts to give them information about the therapy and more. And so I really hope that you'll join us in the mistletoe certification course in cancer therapy. I'm certainly there'll be a link on this page that you can click on to enroll, and I hope to see everybody there. Thanks very much for listening, and look forward to teaching you at the course, and look forward to using mistletoe, this really important therapy, in your practice for your patients.